I'm Tabitha Ortiz. I'm a registered and licensed dietitian working at UF Health. I have more than 24 years experience working in the hospital, and throughout that time, I have consistently worked with stroke survivors. My role with the stroke survivor has mainly been one of an educator. And when I see them in the hospital for the first time, I'm generally met with one of two different types of patients. The first patient, unfortunately, is someone who has had radical changes to their independence, things that the doctors have been speaking about, major deficits that has greatly affected their independence. And stroke is the leading cause of serious long-term disability in the U.S. These patients almost always go to rehab after their hospital stay with the hopes of going home, but some deficits are too dramatic to even go home, and they end up in skilled nursing facilities because that is really the only place that can care for them. I, of course, prefer to see the second type of patient, which is someone whose symptoms have completely resolved or have very mild deficits. We're very frank with them in the hospital and let them know that they've really dodged a bullet, and really use that time to examine their diet and lifestyle habits to see what we can do to improve their likelihood of not having another stroke, because 25% of those who have their first stroke will have their second one within 5 years. So what I do is, as an educator, I sit down with these patients one-on-one, and we really evaluate, like I said, aspects of their diet and lifestyle that can be modified. And I have two main goals. The first goal is to improve the quantity of their life, which really involves improving their overall health, giving them tips and strategies to decrease their risk for stroke recurrence. And stroke doesn't just live in a bubble. If you're at high risk for stroke, you're at high risk for other cardiovascular diseases. So the hopes is to decrease the risk or the acceleration of those as well. Many of these people are also diabetic. So we're talking about proper glucose management strategies on preventing the progression of diabetes and the side effects that come with that. If I'm able to achieve that first goal of improving their quantity of life, I can slide into that second goal of quality. And this really comes down, the key word here is independence. When I started as a dietitian many years ago, I would talk to them about total cholesterol ratios or total cholesterols and hip waist ratios, and that was all really good information. But nobody's ears were perked. I wasn't getting a lot of motivated looks. So you really want to hit them where they understand it, which is they are on a trajectory of losing their independence. And when you say that and you tell them why, suddenly they sit up a little straighter, their ears a little perked, and then they're interested in knowing, well, what exactly do I have to do? So you get a better listener that way. Oh, let me see. Sorry. So I've been asked to speak to you today specifically about diabetics and their risk of stroke and their risk of stroke recurrence. I'm speaking pretty much exclusively about type 2 diabetics. Number one, they're the majority of the diabetics out there, but also they are the type of diabetic most likely to experience strokes. There are approximately 34 million adult diabetics in the United States. There was a recent 2020 review of diabetic statistics that estimates there's probably an additional 7 million people who do not even know that they're diabetic yet. But type 2 diabetics are more likely to have large artery atherosclerosis and experience strokes. So why would we focus exclusively on diabetics as a subset? Well, diabetics are at least 1.5 to 2 times more likely to have strokes compared to non-diabetics. And frighteningly, they have these strokes at a younger age than non-diabetics. They're also more likely to experience post-stroke infections like pneumonias and urinary tract infections. This complicates the management of their care. It often increases their length of stay in the hospital. And the bottom line is post-stroke outcomes are poorer for people who have uncontrolled diabetes. And with 34 million diabetics out there, that's potentially a lot of strokes, a lot of costs, and a lot of strain on the healthcare system. I want to point out, because this is a very important kind of sidebar here that not only is an uncontrolled diabetic more likely to have a stroke, they're more likely to have a multitude of other problems that also run up costs and tax the healthcare system. But I want to point out that diabetics, an uncontrolled diabetic is the #1 cause of kidney failure while people are on dialysis. About 1/3 of the diabetic population have something called diabetic retinopathy, which can cause blindness and is the #1 cause of blindness in those aged 35 to 50. These complications that you see up here are avoidable. They used to be something that was not avoidable, many years ago, but they are avoidable now with proper screening and management. So how does diabetes accelerate your risk of stroke? So over time, these high blood sugars prevent oxygen and other nutrients getting to all parts of the body. These high blood sugars leave fatty deposits and clots and vessels that permanently change the structure of these vessels. Those high blood sugars also constrict the vessels, which help run up your blood pressure. And as previously stated, high blood pressure is the #1 cause of stroke. Diabetics also create an arterial stiffness at an earlier age than non-diabetics. So they lose that elasticity at an earlier age. And you can imagine if they're very rigid, that can aggravate your blood pressure, but it also causes inflammation. Inflammation sets off a cascade of other problems, of other diseases. But in this particular instance, it aggravates blood pressure. It continues to damage those blood vessels. It releases stress factors, and if you're diabetic, those stress factors then aggravate your blood sugar. So you can see you've just been caught in this vicious cycle. We have to mention here that type 2 diabetics are mostly very obese. The statistic is 80 to 90% of type 2 diabetics are either overweight or obese, and obesity is an independent risk factor for stroke, even if you're not diabetic. It's also an independent risk factor for diabetes and hypertension and a multitude of other problems, as you see up here on the slide. Obesity is a highly modifiable factor. You may not be able to control exactly your shape, but you can control to a great degree how big you are. And so we need to use that to help decrease your risk. So what lifestyle modifications do I have to take on? So these recommendations actually work for everyone across the board, whether you're diabetic or not. The first thing is we must evaluate how much exercise we're doing. The Surgeon General recommends that you partake in at least 2.5 hours of moderate intense activity per week. And exercise really helps everything. Not only will this help you lose or maintain your weight, it also burns blood sugar. It's one of my big things coming into the holidays. I tell my diabetics to do, hey, walk before Thanksgiving dinner and then walk again after Thanksgiving, burn that blood sugar. It also helps to lower your resting blood pressure. So it helps with your hypertension and it also decreases inflammation. So there's really nothing exercise doesn't help with. That second bullet point is creating a healthy BMI. Those are the ranges, those are your goals. There are many ways to lose weight, and I don't have time today to really go through all of them, but all will need a caloric restriction. You simply must burn more than what you're taking in to lose weight, and you have to be consistent with that diet. Please do not use exercise as an excuse to overeat. We are such good eaters. You can eat right past any workout that you burn. Just as an example, if you take a 150-pound person and they walk briskly for about an hour, they're going to burn about 200 to 250 calories, and that's good. 1/4 a cup of walnuts is 200 calories. A 6-ounce glass of wine is nearly 180 calories. So you can see how easy it is to overeat right past a really good workout. Improving the quality of your diet is the third bullet point there. Well, the goals, we're going to touch on aspects of the diet that I think are important, but the goals is obviously to create that healthy weight. That's really important. A good diet will also help lower your blood pressure and improve your glucose management, as well as decreasing your blood lipids. So your cholesterol, your triglyceride levels, improving your HDLs. No smoking, that goes without saying. I just want to say 1 minute for alcohol. Excessive alcohol can increase your blood pressure, but I want to say from a caloric standpoint, alcohol is very expensive, as I just mentioned with the wine. It's hard to have really more than a drink without really packing on a lot of calories. So alcohol is very expensive calorically, and if you're trying to lose weight, it can sabotage your weight efforts. So I want to look specifically because I am kind of focused on diabetes, and I often hear a lot of very incorrect information about carbohydrates. I wanted to just kind of dive in and examine the carbohydrate group a little more closely. This, again, works for diabetics as well as non-diabetics because everyone should be watching the quality of carbohydrates. And I think it helps if you think of carbohydrates on a spectrum. So where on the one end you have table sugar, your soda lives over here, all your, cakes and donuts and cookies and candies all live over here. These are poor nutrient quality foods. And when I say poor nutrient, I mean, they're not really giving you any fiber or protein. There's no vitamins or minerals to brag about on this end. And as we move along that spectrum, things get a little bit better. But these are the most refined of the carbohydrates. So when people tell you, oh, decrease your intake of refined carbohydrates, these are what we're talking about. You can eliminate these altogether. These are the types of carbs that you can obviously consume the least. These have a very high glycemic index. They're going to run that sugar up, and they have a poor satiation quality, meaning they don't help you feel full. Think of how many donuts you could pack away or pancakes or whatever, and you're like, I don't feel full yet. So that's what they do. They don't let you feel full, and so that by the day's end, you've consumed a lot of calories. These simple carbohydrates are also all on their own cause inflammation that I mentioned before, and that inflammation again sets off a cascade of other problems, of other diseases associated with it. Obviously, if you're trying to lose weight and create a caloric restriction, that's better achieved with foods that make you feel fuller longer, right? And that's going to live at the other end of the spectrum. So those are your complex carbohydrates. Now, there are some that are better than others. White rice, yellow rice, mashed potatoes, they're all complex carbohydrates. They are not the best of the complex carbohydrates. You want brown rice, black rice, whole wheat pasta. If you're going to eat the potato, I want you to wash it really well, and I want you to eat it with the skin. Most of the vitamins and minerals and fiber are in the skin of the fruits and vegetables. So I want you, when appropriate, to wash them, and I want you to eat the skin because that's going to give you that fiber. It's going to help improve your blood lipids. Those are the low glycemic index foods. Those foods are going to help you feel fuller longer. And if you think for a minute, kind of a theme of this spectrum we created, it's the less processed, the better. And I think that's the best theme that you could put on your diet for overall health and to help decrease your stroke risk. Well, it wouldn't be a stroke talk if I didn't talk about salt. I was looking up the average American salt intake just to compare it, and I was kind of surprised. They said the average American salt intake is about 3,400 milligrams. I think that's a very kind estimate. I think that I've seen people who are easily 5,000, 8,000 milligrams a day just based on the types of foods they're eating. The dietary guidelines for Americans recommend that you take in less than 2,300 milligrams a day. However, if you're already diagnosed with a cardiovascular disease, hypertension, or congestive heart failure, your doctor may ask you to decrease that just a tad to maybe 1,500 to 2,000 milligrams a day. Studies do show that salt does exacerbate your blood pressure. So where are we getting our salt? Well, as I stated before, we're really getting it from processed food. When I see patients, they always say, oh, I don't use a salt shaker. But the salt shaker is only about 10% of your intake of salt. So, I say that's good, but what are you eating? And so you find out these foods, salted and cured meats like bacon, deli meats, hot dogs, canned soups. I like the analogy of shopping on the outside of the grocery store and watching what's in the aisles, anything that has a seasoning packet. You can even have some of that good brown rice that I told you about and it has a seasoning packet and whatever mix it's in. That should be a red flag that I need to look at this label. How much salt is in there? Can I add my own seasoning? So anything with the salad dressing, sauce, gravies, etc., those should be red flags for little pockets of salt. There is nothing high in salt that's fresh. It's something that we did to it, processing or how we've marinated it has caused it to be high in salt. Salt is a wonderful preservative, so it helps those items be shelf stable longer. It is also a flavor enhancer. So some of your low fat foods will have added salt to them. So if you see that something's low fat, I want you to double check that that nutrition facts label and check for the salt, because they're making up for the flavor loss with extra salt. The annual costs of stroke are huge, not just the financial costs, but the physiological costs. And, Dr. Khanna put up that 80% of strokes are preventable. At first I was devastated by that, but then I think that's a good sign. 80% are preventable. That's a lot of room to move to get it into, decrease that value, to know that we have that effect. And you have control over many of these aspects, many of these variables that influence your stroke risk. Do not rely on more medications as opposed to taking accountability of what you're doing. I'm not saying not to take medications, but medications are supposed to aid your efforts, not replace your efforts. So be sure that you're doing your part as a consumer, as the patient, to improve your health. You are actually the most powerful variable in all of it to improve the difference in your health. And I hope I've inspired you to do that today. Thank you very much.